Yes, sir. Thank you. So I have the distinct pleasure to introduce Dr. Doberstein today. He is Professor of Neurosurgery, Executive Vice Chair of Clinical Operations, Director of Cerebrovascular and School-Based Surgery, and also a Director of the Neurosurgery Residency Program at Brown University. Here we can see some selected education in his positions. He got his medical degree from McGill University in Montreal in 1988. From there, he moved to UCLA, where he completed his internship, neurosurgery residency, and his postdoctoral research fellowship in Los Angeles. And from early in his career, he moved to Brown University. From you can see he got his assistant professorship, then associate professorship, and right now his full professorship. As I just mentioned, he's vice chairman and also director of the vascular and school-based surgery. We also included some of his selected honors, as well as a narrow one that he got in 1999 from his work on choroid plexus, growth factors, aging, and injury. From here, we can see his impact from early in his career, from all the way from 1990, 1999 until today. And here we have some selected publications. Of course, you can see the high impact he has done in the literature. And here we have a plaque that we designed for you, sir. We will send it your way as soon as we conclude this lecture. And thank you so much for joining us today and spending time with us. I'll leave it for Dr. Tuck and Dr. Q to give further comments. Thank you.
I have such fond memories of coming to visit Brown, a few years back with Kurt and having some great dinners, great discussions with you and with Zia. And I'm taking some pictures, obviously, because I'm gonna text them to you and to Zia and everybody. Welcome, everybody. Dr. Doberstein is an amazing leader, an amazing surgeon. And what people may or may not see is also he's an amazing human being, just kind, caring, giving, an amazing leader in the field. So we're honored to have you here, Curtis. Very, very honored.
Thank you very much. That's very kind, Q. And Carlos, thank you for that introduction. Well done. That was, I feel old now after seeing all these things and you're putting dates. I've been here, I'm coming up on 30 years and I realize all these grays I've earned. But thank you, very kind. I was blown away this morning, by the way. That was fantastic. Zia and I are going to have a powwow, Q, later on this morning and maybe revamp how we're doing things at our teaching conferences. That was really good. And boy, that oral boards preparation from JP was great. That's a really good case and really a good discussion around it. Really difficult case too, but impressed. And so thank you for having me. Now, how do I share my screen? Let's see here. Who's got access?
Yeah, you're co-host now, sir. So just click on the bottom of your screen, says share screen in green.
Got you. And let me see then if I just double click on this. Well, that didn't work out well.
Yep, that's great.
We see your PowerPoint now, Curtis. He's not in presentation mode, but he's there.
All right, let's see if I put it in presentation mode. How's that?
It looks good. And
all right.
Maybe go to the display settings, to the upper left and the display settings, and that arrow up, yeah, right there, display settings, and then put presentation up above, yeah, right there. If you click, it'll be, is that it, Carlos, right there?
Yes, so I'll present you.
Mm-hmm. Yeah, swap presenter view. There you go, perfect. Now we got it perfect.
Awesome. All right, well, thank you for having me. Tough to pick up a presentation. You guys do everything for me to pick a topic. The only thing that I didn't realize is that I don't know how many Tcars you guys have been doing, how active the program is. For us, it's relatively new. We started doing Tcars about 3 years ago, maybe 2.5 years ago. Prior to that, I am not endovascular trained, so I'd done about 1,000 endarterectomies, and we've been following the endarterectomy practice very closely. And when we started going over to trying Tcars, I was just thoroughly impressed with the technique. And so I thought it'd be nice to give a little bit of review. I don't know, have you guys done a lot of Tcars before I get started?
Well, our group does, I've started it basically, I mean, back in the trial. And so what we do is we take care of our carotid patients. Basically, vascular surgery gets most of the referral by the Mayo criteria, but when we see those patients, we take care of them. And colleagues also from vascular surgery do it. So it's scattered between providers, but as a volume, as a center, we love this technique, and we all do it, and we consider every single technique for the carotid: proximal protection, flow reversal, endovascularly as well, distal protection with filter protection, and the standard endarterectomy. But we're very curious to see how you select your patients, and coming from you, where is the place for this technique? Because you can do carotid with every single technique. So
yeah, that's all. Yeah, you're absolutely right. So we'll get our criteria for who we select for Tcar I'll describe that as I get on into the presentation. It's a work in progress, and a shout out to Charles Matuk, if you guys know him from Yale. We've been working together on this, trying to come up with criteria for who we feel are good candidates for Tcars. And I'll talk about that in a bit. Also, I need to acknowledge one of our residents, Josh Feller, who helped put the presentation together for me, because I'm technologically a little bit behind. And so he told me he didn't want me to embarrass the resident team by having ugly slides. I usually pick bright colors. So. All right, the first set of slides, I didn't know where you guys were in Tcar. I'm going to go through these fairly quickly. These are given to me by Silk Road, which is the company that makes the materials for Tcar. As I told you, endarterectomy is near and dear to my heart. I've been doing it for nearly 30 years. As I've told you, we have about 1,100 cases we've done endarterectomies on. We're a very busy stroke center. We get, unlike the Mayo system, which I'll have to learn more in detail, and we have a very close relationship with the neurology department. We are a comprehensive stroke center, and all the symptomatic or asymptomatic patients that come in through neurology get referred to neurosurgery. We have a really good vascular surgery team as well. They predominantly do asymptomatics. They have a bigger referral base, mainly from the community. So that's why when we look at our data, we are really heavy with symptomatic cases. They do less procedures, but are a little heavier in the asymptomatic side of things. As you know, endarterectomy has been around for a long time, 65 plus years. It's really the standard that we look at when comparing other interventions. I won't get into too much of a debate about transfemoral or radial artery stenting, peripheral stenting. It's a great technique. I think that stroke rates, at least in our institution, are fairly similar. Our results have paralleled very much the CREST studies, in that there's a slightly higher risk of stroke, typically non-disabling stroke, in peripheral artery stenting. There's certainly a higher risk of mortality and myocardial infarction after endarterectomy. But it really does parallel those. And I think that the impetus for Tcar was based on the fact, with CREST-2 ongoing, is there still another safer way? Can we combine the advantages of peripheral artery stenting and endarterectomy and come up with a novel approach to even reduce the risk further, albeit it's a fairly small risk to begin with. For the residents, I never understood with NACIT. I was a NACIT member as well as an ACAS member. And when the NACIT studies came out, I could not figure out why older patients fared better with endarterectomy, not stenting. Because early on in my career, my bias was towards the elderly patients, send them for stenting. They're elderly, they're sick. And it turns out not to be the case. And that also paralleled our experience. And it was really the endovascular guys who taught me that the aortic arch is what they fear the most. The calcifications along the arch when they're passing wires through, not so much the lesional anatomy, but it was the arch that led to, I think, the higher risk of stroke in those elderly patients. And endarterectomy obviously avoids that. I'm not going to go into all the previous studies looking at it, because I think you guys know that well. The techniques are fairly comparable. But the advantage of Tcar when it was developed was minimally invasive. Certainly the incisions are much less than an endarterectomy. It avoids going through the arch with any type of catheter work. Cranial nerves are not in peril with a Tcar or a peripheral stent. The concept of flow reversal, which we'll talk about for a little bit, is certainly appealing on a basic level. The fact that you are reversing flow in the carotid artery so that any debris won't go antegrade, will go retrograde through your system. And then the accurate stenting, I think my endovascular colleagues say, oh, we can do accurate stenting can be done through any approach. But certainly the early data with Tcar, comparing it to carotid endarterectomy, not to peripheral artery stenting, showed that there was less risk of MI, certainly less risk of cranial nerve injury. It was a quicker procedure with a shorter length of stay, and there was less risk of bleeding, in this case, hematoma. And those, if you guys do a fair number of endarterectomies, there's always once a year that you get called back in the middle of the night for a significant hematoma. That is less with any type of Tcar approach. For the residents or any of the faculty who haven't done a Tcar, it is basically access of the common carotid artery above the clavicle. We get control of the common carotid artery with vessel loops. We put in an access catheter into the common carotid artery. That's the working port. So we can do any of the wire work or angioplasty stenting directly through that access. That catheter is then hooked up through a backflow tube with a filter that goes directly into the femoral vein, so that when we clamp the proximal carotid artery, we institute reversal of flow, that blood is going back through the filter system into the femoral vein. So it's a continuous loop. And basically the way it is set up is blood flow, as I described, in the common carotid artery. Once it is clamped, we start reversal of flow. It goes through the tubing, which has a filter in it, and goes directly back into the femoral vein. And that working port up in the common carotid artery, as I said, we can do the stent, we can do the angioplasty, angiography, anything that's needed through the port itself. This was just a picture. This is the tubing that we had a recent case, just removing it, showing you this is the debris that can be picked up through the filter. This was a fairly soft plaque, but that's the debris that with reversal of flow is getting caught in the filter. You can imagine if there were antegrade flow towards the brain, all those little particles would have been a major problem. Okay, enough for the basics of Tcar, because I think you know that. So now we're going to go on to what has been our experience with Tcar. We've done about 120 at this point, Tcars, and we decided to start looking at the symptomatic patients. A, it was our bigger patient population, and B, we knew it was the sicker population with higher risks. And so that's what we wanted to select out in our initial studies. Shout out, I'm the low person on the totem pole. I have a tremendous amount of colleagues. Radomir Tarabi, Christina Moldovan are both faculty here. They trained here, they did their endovascular fellowships, and I've learned a ton from them. The residents have been very involved in the cerebrovascular program. As I mentioned, Josh Feller, Matthew Anderson, John Poggi, all terrific residents here, all very interested in cerebrovascular disease and have been instrumental, along with the medical students listed at the end. Have just been terrific. I'm very blessed to work with a terrific team. So our approach to symptomatic stenosis is we work with the stroke neurologist closely. They admit the patients, they handle MRIs, cardiac workup, coagulation workup. And for me, I'm but the lowly surgeon. I look at it, if there's carotid stenosis in a stroke, it's related to carotid stenosis. Well, I'll take a pause for a day or two and let our neurologists do their thing. And sometimes I'm surprised. We'll talk maybe at the end with questions. What do you do about the patient with AFib, who you're not sure whether it's the carotid stenosis or the atrial fibrillation? Loaded question. We try to revascularize our patients within 2 weeks. from the event. Certainly anybody with moderate or severe stenosis who's symptomatic, we typically treat. I understand very much that the moderate category, particularly in women, is very controversial. My philosophy has always been on symptomatic patients to be much more aggressive than asymptomatic patients. And obviously plaque morphology leads into a whole other decision making. We try to select the best fit technique based on a number of parameters, and we'll go through those. And I'd love to get some input at the end. As I told you, Dr. Matuk from Yale, as well as our team here, have been together trying to come up with a standardized approach to who would benefit from Tcar versus endarterectomy versus peripheral stenting. At our institution, in general, we prefer Tcar and endarterectomy over peripheral vascular stenting. We do peripheral vascular stenting, and I'll give some examples at the end. But our endovascular trained neurosurgeons also prefer Tcar over peripheral stenting. It's funny, my endovascular colleagues typically shy away from endarterectomy, but I think that that comes with time as they do more. Clearly, peripheral access stenting is a great technique, and I don't mean to bash it here at all. I'm just telling you our bias. Multiple studies, CREST, SAPPHIRE, ICSS, have shown that it's really on par with endarterectomy. There are some nuances, as I alluded to initially, about endarterectomy having a slightly higher rate of MI, peripheral artery stenting, slightly higher risk of stroke. However, I think as a whole, if you take a step back, they're fairly equivalent, particularly over a 10-year period. When we're looking at the risks that I talked about, it's really, that's the 30-day MACE, not the 10-year. When you look at the 10-year data, they're really equivalent techniques. I'm not going to go into Roadster. I'm going to skip some for the sake of time here. Okay, so the advantages of Tcar we briefly alluded to is that you have direct access to the common carotid artery and distal ICA, which obviates the need for having to navigate the aortic arch. Flow reversal limits the concept of embolic events traveling northwards towards the brain, but instead will go retrograde through your collection system. And there's a minimal loss of blood since you're directing the blood flow directly back to the femoral vein. There are limitations with Tcar, however. Tolerance of flow reversal is theoretically limited in patients with an isolated hemisphere. We teach our residents when we go through the Tcar decision-making tree to look at communicating vessels. Is the contralateral occluded, carotid occluded? I am shocked. We have never had a patient not tolerate flow reversal. And now we're up, as I told you, we're close to 100, 120 cases at this point. They have all tolerated, even patients that have had what appeared to be on CTA an isolated hemisphere. Contralateral occlusion, maybe a hypoplastic A1, maybe a wisp of a PCOM, hard to see on a CTA. They have tolerated the procedure well. That is in contrast to when I do endarterectomies. No doubt about it, that our shunt rate with endarterectomy is around 5%. I'm a selective shunter. But I believe the difference is when you do an endarterectomy, you're placing that clamp on the internal carotid artery distal to the bifurcation. I think with Tcar, it's my belief that even though we have flow reversal, there's still some contribution from the external collaterals, that it's not complete isolation of flow. It's a relative isolation of flow. I have no evidence to prove that whatsoever, with the exception of the patients just tolerate the procedure. We monitor EEG, we monitor oximetry, we monitor evoked potentials. We have not had to abort a case during flow reversal at all. So in our cohort, these were the first 63 symptomatics. As I told you, this was from about 6 months ago when we put these together. The demographics, this is a sick population when you're talking about symptomatic carotids. The patients have a lot of comorbid medical disease, diabetes, hyperlipidemia, coronary artery disease, of course. Many of the patients are smokers. This is a sicker population who you're going to expect to have a higher complication outcome with them. And that needs to be factored in. That's why we selected just the symptomatics to look at first. Determining whether they were Tcar candidates, we looked at pretty much the classic criteria, and that was what were the high-risk features that would lead us away from endarterectomy. They may be contralateral carotid occlusion, although you could say you could just shunt. This is a relative contraindication. Tandem stenosis, restenosis after endarterectomy. I've given up in that business. I will fully say stenting of any form is better than having to redo an endarterectomy. It's just no fun. High bifurcation. There's difficulty with anything, at least with my exposures. Above C2 is problematic. At the top third of C2 is problematic. Anything below that, we can typically get to, albeit there are going to be difficulties with exposure with the hypoglossal nerve, etc. Hostile neck. I'll show a case at the end who was the brother of our chief of anesthesia, who had irradiated neck from oropharyngeal cancer. And those of you who have operated on endarterectomies with a radiated neck, that also is a whole different disease set. There are some physiologic characteristics that led us towards Tcar. If the patient had a contralateral vocal cord paralysis, if they had an elevated cardiac risk, MI within a window of 72 hours to 6 weeks, and severe COPD, those were all patients we decided to put into a Tcar category because they were high physiologic risk for an endarterectomy. And we had a pretty equal side, right, left. We did general anesthesia on the majority. There were, in this series, 1, but we've done 2 under local. That's in contrast. I used to do a lot of my endarterectomies for a period of time under local anesthesia, and they were discharged the same day. And we had a series of about 60 to 70 patients. Our residents wrote it up, and we had a really good outcome with it. But about 5-6 years ago, when Zia joined us, I was stopped by the institution because the DRG was for an overnight stay. So the hospital wasn't getting paid for my outpatient endarterectomies. And so then that became not a battle, became a discussion of what's safest for patients and what's medically economically possible in the state of Rhode Island. But then we went back then to not doing them same day, keeping them overnight for a 23-hour stay. The patients, as I told you, had high flow tolerance, meaning that on your setting, on your Tcar device, there's a high flow, there's a low flow. High flow is just what you mean. You're getting a high reversal of flow. Most patients tolerate that, but we had a few patients that didn't. But when we clicked down to low flow, everything settled out. EEGs, oximetry came back to an acceptable level. And in most of those cases, you could then resume the high flow. It was just letting the collaterals build over a period of time. Technical success was great in all but 1 patient. And the 1 patient that wasn't a technical success, we did the angiogram and there just wasn't bad stenosis. The CTA had overread. We had overread the CTA with the radiologists, and the angiogram really was mild stenosis top. So we elected not to place a stent in that patient. Otherwise, the success rate has been high. Lesion details. Again, there are certain characteristics we'll briefly talk about that are good candidates for Tcar. The bifurcation distance to the clavicle is 1. You want to see it over 5 centimeters typically, enough to get your wire, typically your initial J wire in without crossing the lesion. Stenosis, as I told you, our practice is 50%, and moderates to severes, if they're symptomatic, we will do. If the mild patients, we have a couple that have been mild but have had carotid webs, or a bad ulceration with 2 strokes in a short period of time, those patients we intervened on as well. They're not in that series. We took the webs out. Contralateral occlusion was present in a couple patients, tandem stenosis. Some patients had high bifurcations, more than I realized. We use C2-3 or mandible in the way. C2-3 to me is accessible, but my colleagues pick that as their basis. As I told you, for me, it's that upper half of C2 I start worrying about, gets a little high. The base of C2, I think, is accessible, just a little bit more work. and prior CEA for the patients that had previous CEAs. Our outcomes on this initial series, we had one minor stroke. Patient came back, I'll describe it, a couple weeks later with a non-disabling stroke, but we did get an MRI, as we do on every post-op that has an issue, and there was a small diffusion restricted area in the frontal lobe. We did not have any disabling strokes. We had one non-STEMI, MI, no STEMIs. We had, we'll talk about this, 3 mortalities. High, right? 4.8%. That's in standard, by the way, with symptomatic carotid stenosis for mortality. But as all researchers, Dr. Q will tell you, all of us, it drives me nuts that 2 of these patients, one died from gastroenteritis and one we think died of COVID, but we're not sure yet. Not really related to the procedures, but they count. They are your mortalities. So we included them here. We had 0 cranial nerve injuries, despite occasionally seeing either the vagus or the recurrent laryngeal coming through. There were no cranial nerve injuries. We did have 1 neck hematoma. It was our first case. And I learned a lot about the vascularity of the thyroid gland. We got a bit into the thyroid on exposure. It bled a lot. We were able to stop it, but post-operatively, the patient had a hematoma that we had to reopen for. We had 1 asymptomatic carotid dissection that we picked up on post-operative imaging, but since the patient was on DAPT anyway, we didn't do anything about it. We followed him. Major morbidities, as I alluded to, one I think was potentially related. That was an ipsilateral basal ganglia hematoma that occurred a week after surgery. Wasn't a stroke, but it was you could argue related to hypertension, but it also could be reperfusion injury. And then the other complications I alluded to was a gastroenteritis, death of unclear circumstance, we believe was COVID, and the other complications I talked about. But the risk profile in that data is terrific compared to our endarterectomy data and our peripheral stenting data. So preliminarily, we're very excited about it. I'll try to finish it up, and I hope I'm not I hope I'm covering what I need to cover, is selection, patient selection. We talked about it. This is a work in progress for us. So what we did is we sat down with Charles, we sat down with our interventional neuroradiologists, non-neurosurgeons, and our endovascular neurosurgeons. And we said, you know what, let's come up with a criteria. What do you guys think would be good cases for endarterectomy, good cases for Tcar, good cases for peripheral vascular stenting? Let's come up and see if we can come up with a consensus on how to approach it. So in this case, we arbitrarily took a scoring method of 1 to 4, with 1 being, hey, I don't want to do this. This is really contraindicated. To 4, this is a great case for it. And then the 2s and 3s were in between. So high risk for general anesthesia. This is determined by the anesthesiologist or a cardiologist. We all felt that peripheral vascular stenting was the better option there. But that endarterectomy and Tcar were still reasonable options. It just really depended on what the risk of that for general anesthesia was. Aortic stenosis is a different disease than exercise-induced chest pain. It really is. A hostile neck, we defined as previous endarterectomy or radiation on that side, or significant surgery ipsilaterally. We all felt endarterectomy would not be a good approach in those patients, but that Tcar and peripheral vascular stenting, perfectly acceptable. It wouldn't affect it. Prior CEA, same thing. Age greater than 75, I don't think phased any of us, but there was a slight favor towards Tcar and endarterectomy over peripheral vascular stenting, in the sense where, again, you have to go through the aortic arch, and I think that some people weren't thrilled with that in the older age group. In our population, it's a real issue that DAPT noncompliance, intolerance, or socioeconomic disadvantage in terms of being on these medicines. We like to have them on DAPT for about 3 months. There are some patients that just can't afford it, or they are just non-compliant, won't do it. And those patients that they would be acceptable for an endarterectomy, and that's what we do in those cases. But we try to avoid stenting where it's required that they need to be on these medicines for a while. Therapeutic anticoagulation within a week. I think everything was equal. None of us had a big problem with that. That's usually the patient that is an AFibber that needs to go back on Eliquis, or had a DVT that may need to be placed on anticoagulation for that. Severe cardiac disease. This was a strong consensus, all agreed that that should be done peripherally. And that's usually the patient with bad aortic stenosis. Our anesthesiologists are really weary of aortic stenosis. Contralateral vocal cord paralysis. Obviously, endarterectomy would not be a great choice in that patient. And we lean towards either peripheral stenting or Tcar in those patients. Again, this is subjective, but I think it gives you a pretty good idea based on a neurosurgeon's perspective, our interventional neuroradiologist perspective, on what would be appropriate cases for Tcar versus the other technique. Again, there are some anatomical considerations. I'm just going to check time. I'll try to wrap it up quickly. Tortuosity distally can be difficult with endarterectomy, particularly if it's a retropharyngeal carotid. Also, distal tortuosity can be an issue with Tcar and stenting, given the fact that you have to get a catheter through that segment. Also, placing a stent in a double loop can be technically difficult. Retropharyngeal ICA, tortuosity of the common carotid artery can be difficult with a Tcar. I haven't done it yet, but one of my colleagues has either gotten into the subclavian or the vertebral with their initial angiogram, and that was a very tortuous carotid that they had difficulty accessing. High bifurcation also leads you away from endarterectomy. You have to get your clamp above that disease. Some of the technical problems I've seen with endarterectomy have been a distal clamp just not being quite far enough along. And if you get that distal plaque, it's a setup for problems. A low bifurcation is very difficult to do a Tcar with. You don't have enough. If you have less than 5 centimeters, or certainly less than 4 centimeters, it's not enough working access to safely get your initial catheter and wires in, because you could access the lesion prematurely before you go on reversal of flow. Isolated hemisphere, I think all 3 can be done fairly well. What we found is Tcar has not been an issue with any EEG or electrophysiologic changes. Certainly with an endarterectomy, you can shunt. I hate shunting personally. I'm a selective shunter, and I've gone from Javid shunts to Argyle shunts. I keep switching around trying to find a good shunt, and realize that in my hands, or my case, there is no good shunt. I hate to shunt. It's just, it's doable, it's feasible, it's fine, but there are issues with shunting as well. And certainly the risk of stroke, when you look at the literature, is slightly higher with shunting than without. I won't go into too much detail about lesional considerations when we went through this, with the exception to say that if there is concentric fully around the artery calcification, we tend to do endarterectomy. And I think that's true. All our stenters don't like placing stents through heavy calcifications. Although I can tell you, each month that goes by, we're getting more and more aggressive. We did one last week that was really concentrically calcified because the patient did not want an endarterectomy. Looked surprisingly good afterwards. We do in those cases a pre and post angioplasty when we place the stent if they're heavily calcified. Couple quick cases. This is the one I told you about that had a radiated neck, was the brother of our ex-chief of anesthesiology. He had an occluded contralateral ICA and an occluded vertebral artery, and had about 80% stenosis on the left side here, and had a previous radiated neck. We felt he was a good candidate for it. He had evidence of hypoperfusion. We had an MRI rapid on him, and he was hyperperfusion, had intermittent contralateral visual changes, almost close to transient binocular blindness. Because of what we define as a hostile neck and evidence of hypoperfusion, we thought he was a good candidate for a Tcar. Endarterectomy may be problematic. I think he could have gotten a peripheral stent as well, but we went through with a Tcar on him. This was his lesion at the time of our initial angiogram on the left, and post-stenting was on the right. He tolerated it well. He was one of the ones we had to go on low flow with, as opposed to leaving him on high flow reversal. He did start to get some EEG and evoked potential change, but once we went to low flow, he tolerated it well. I think our clamp time on him was about 12 minutes. High bifurcation, we talked about. This patient not only had a high bifurcation, but our spine surgeons certainly did a pretty long construct on him. They had come in on the side of his symptomatic stenosis as well. So we felt that in his case, that a Tcar would be a perfect approach for him. And he had both sides done. We delayed them. He was symptomatic on the left, asymptomatic high grade on the right. We did both, and these were the results. He did very well. Required 2 stents initially on the left side. It was a long lesion. And the last is the calcified carotid. That 5 centimeters I alluded to on the common carotid artery, you really want to avoid any calcifications in that artery, because if you're putting in your catheters and your needles through there, you hit some calcium on the way in, you can get into trouble. And this is a guy, let's see if I can get that to stop right there. Nobody wanted to do this. If you look at this left side, the whole carotid, I'm not going to get that back. Do this. Oh, well, there it is. This left carotid, the entire thing is calcium. From the common up to the bifurcation was just a chunk of calcium. I was not thrilled about doing an endarterectomy on it because I didn't think I could get under the plaque. I would be under the clavicle. Tcar is out. You can't access that common carotid artery with the Tcar. And we finally talked to one of our interventionalists to do a peripheral stent. And I thought she did a great job, all things considered. Let me show it right here. This was the angiogram pre-op. And here she had placed the stents along there. I realize it doesn't look perfect, but I think in that circumstance, that's the best you can do with the techniques we have. Okay, I'll stop there. And let's see if anybody has any questions or.
Great talk, Kurt. You know, in particular, I mean, I really enjoyed your talk. In particular, I liked your what you call subjective selection criteria. And I don't think it's subjective, it's just, it reflects your expertise, because knowledge is power. And for many cases, we talk about individualized medicine. You want to do for the patient what's the best thing available. And with the variability of carotid disease, now we have almost every technique. So congratulations. I just have a few questions about patching or non-patching, just a few, I want to go straight to them basically, but quick, yes, no, and why?
Patching, sometimes, maybe. Carotid less than 1 centimeter, I'll patch.
Okay.
A redo, which I've done obviously many redos, I'll patch. Otherwise, I'm not a routine patcher. And the problem with that is a lot of neurosurgeons aren't routine patchers. And the view, as you know, the VQI and the vascular groups, they want patches. Our vascular guys patch everything. But I'm a selective patcher. I'll do it for the small carotid or the redo, but the native big vessel that I get a good endarterectomy on, I'm very happy with the primary closure.
Wonderful. IR or OR setting, you do Tcar. Many places have the full hybrid rooms. Some of us have some activity in the OR with the C-arm. Sometimes we go in the IR. I do it in the IR. Our vascular colleagues have a hybrid room, but where do you do it? And give us some hints. And so.
Our vascular guys also have a hybrid room, and we're very jealous of that. so I can get Q to work on Zia to help us get a hybrid room before we're through. The advantage of using using fluoroscopy is that we can go to any room in the OR. And the images have been really pretty terrific. We have pretty updated fluoroscopic equipment. So it is nice having that mobility. Now, Charles wants us to start doing them in the IR suite like you're doing, because he wants to do a study doing thrombectomies through a Tcar approach with flow reversal. I think the concept is great, but right now we are so staff limited with nurses in the OR that when I broached it with them about 6 months ago, I basically got laughed at. They just said, we cannot take an OR team off to the interventional suite. We need all hands on deck here. So I would love to be able to do Tcars in the IR suite, but currently we can't.
Great. And you brought my attention to awake versus sleep when I was in Buffalo. Nick Hopkins was a big proponent of everything awake and endovascular. When I asked him about endarterectomy awake, his answer was to me, I hate it. I said, why, boss? He's like, they snore. I'm like, boss, give me a better excuse. So what's your thought on local for CEA?
I started out doing them all under general, and I'm good friends with Bob Harbaugh. When Bob was at Dartmouth, he came down and trained me how to do them under local. So I switched to local. And then what the next shift of local was, look, these patients are awake. I'm getting ultrasounds in the recovery room. Why don't I just send them home? So that's what I started doing for about 60 cases in a row. I did them under local. I kept them for 4 hours. I personally examined them. I make sure I had a Doppler in the recovery room. Everything looked good. I'd send them home and I would call them that night. Probably like Q does. On my way home, I just call them 8, 9 o'clock and say, hey, how you doing? Any neck swelling? They did really, really well. The only disadvantage that I found with local anesthesia was language barrier. So some of our patients, particularly Portuguese speaking, if I had a translator to come help, it was okay, but language got to be difficult. Claustrophobic patients, there was 2 patients I can remember that got very claustrophobic under the sheets. And we either had to change our whole draping setup or whatnot. Now, having said that, I alluded that the hospital really asked me to put it on pause because they didn't like the same day discharges for monetary reasons. And once I switched back to general anesthesia probably about 6 years ago. I don't favor one versus the other, but I got to tell you, general anesthesia is easier from a flow standpoint in the OR. It just is. But I do like local anesthesia, particularly with the COPD patients that are really bad. We'll revert to local on those patients.
Wonderful. Thank you so much.
You're welcome.
Dr. Doberstein, thank you. This is Wala. I'm one of the vascular fellows. I just had a quick question. Do you think the long-term results in these Tcar approaches or stenting in general are superior than ENDART? And the reason why I ask is because with the Tcar, you've kind of done half of the ENDART already, right? You've dissected the carotid out, you have it exposed. So what's the kind of, there must be some kind of long-term advantage of putting a stent in versus just cleaning out the artery directly.
That's a great question. I don't think Tcar gives you half the access to the carotid because you're way under the bifurcation. You're 5 centimeters away from where you'd be doing your endarterectomy. Our stroke neurologists do not typically like stents in young patients, and I'll arbitrarily define that as under 50. And their argument for that is that we just don't know the long-term outcomes with stents 20, 30 years down the line. My counter argument is, well, I do know it with endarterectomy because we've been following it on this line. And there is a restenosis rate with endarterectomy that is small, but really present. I'm sure you guys see it all the time in your practice. I'm going to throw out a number about 5%, and that may or within the range, but there's that restenosis rate that is not inconsequential. Certainly with stents, there is restenosis within the stent. I had a patient a couple of weeks ago that had a peripheral stent a couple of years ago that was occluded. So there are issues, but long-term, we don't have the answer to it. It's particularly with Tcar, with these en-route stents, we've only been doing it, what, a decade maybe.
Hey, Dr. Doberstein, David Miller. I'm the interventional neuroradiologist and director of the Stroke Center. Listen, thank you very much for the talk, and let me congratulate you on some fantastic results. You obviously, and on top of that, the presentation was probably the best I've heard in truly looking objectively at all these different procedures. So I congratulate. Thanks for joining us. It's interesting. The long term. Yeah, when I came to I started doing stenting as a part of the CREST trial, and I was a little concerned as well because, you know, again, in the hands of a good surgeon, endarterectomy is a great operation, and you know, it's obviously much different than the cardiac situation where it's a much more invasive thing. So when I started doing them, I didn't know. I have been pleasantly surprised that my restenosis rate with far as stents has been quite low, probably similar to what you're seeing. I think the literature says 5% at 3 years. Mine's been a little less, but similar. And I think that, yeah, but I don't think it's that much different if you operate or if you stent. It's interesting that you said that the patients seem to tolerate the reversal of flow quite well. That's a really interesting point, because I think that's one of the arguments that many of us who do peripheral approaches, especially with distal protection, say, well, you know, we're decreasing significantly the amount of time in which we're under reversal of flow. You can get reversal of flow, obviously, with MoMA and things from the peripheral area, but I use it only when I feel like I need it. So it's really interesting to see from your data that your patients tolerate that degree of reversal of flow. It makes me, I do the Tcars in conjunction with my surgical colleagues who give me the approaches, and makes me a lot more comfortable about approaching it that way in the future. I was wondering, you know, we do people over 75 here in Florida all the time. If we restricted people to under 75, and I'm not sure we'd have a clinic, but it's and under 50 for us is pediatrics. But we do have quite a busy practice. I haven't seen as much trouble with older patients as long as the architecture isn't any different. I mean, I think it's more an architectural thing that we've seen rather than a calcification and the architecture rather than the age. But it's interesting. Have you guys taken a lot of look at your degree of calcification?
Not in that detail, and it's a good point. We arbitrarily picked 75 because that was based out of NASTA in CREST 1. So we arbitrarily picked the 75, and you're 100% right. Some 75-year-olds have a perfect arch, and some don't. It's really variable.
And then the other is, as far as stenting goes, with are you looking to alter the type of stent or the that you, I know with the Tcar you've got a specific protocol, but are you guys looking at anything with the type of stent you're placing vis-a-vis plaque morphology, that kind of thing?
Not yet, but it's being discussed. And the problem with that is the access port for the Tcar. You have to make sure that whatever stents you have are going to go through their access port. So we've actually started talking with Silk Road about that. Yeah,
so I think that's, because we all talk about what can you see on MR, and everybody wants to look at plaque morphology. But I don't know that anybody's really looked about whether, and I think there may be an indication for the different porosities and different types of stents based on what the morphology looks like.
I think you're absolutely right.
Wonderful.
Maybe we need to talk to you about that.
Yeah, I agree.
Thank you, David. Well, Curtis, you can see tons of interest, tons of questions, tons of comments. We thank you. I mean, spending the morning with us. I saw the schedule. Carlos put it. You're going to be meeting with the residents and fellows right now. We'd love for them to pick your brains about residency, pearls. How do you run a busy practice? How do you get an NIH funded, which you have done? How do you go ahead and make sure that you continue to train the future generations? What sort of techniques you're using? So I would love for our residents and our fellows to hear from you. And many of these fellows actually are applying to residencies. So it's important for me that they get to know leaders like yourself in the field. And then you're going to be meeting with some of us for a few minutes, and then at the end I'll wrap it up, and I meet with you again at 9 a.m. for what I see right here on the schedule. I think they send you the different links.
They did,
and I apologize. A packed morning for you, and we really thank you immensely. It's such a beautiful, wonderful talk. You can see lots of compliments. I saw Gabriel, all the way from Bucaramanga, from Colombia, commenting. A lot of people from around the world that benefit from this type of talks. That really show us what we can do if we work together in multidisciplinary teams. So thank you, Curtis.
Thank you, Q. And I can't imagine having a better mentor than you leading the program. What a team you
Well,
put together.
You're very kind. And I
Bravo.
love how the fellows don't send you the plaque before. They said after your talk. I'm like, man, these guys are tough. All right, I'll see you in a few
Love it.
minutes. And then Carlos, he's gonna reconnect in a different link. Is that what's going on?
Yes, sir. We send the link to his email. So yeah, we're gonna close this meeting and
Got it.
join the next one.
Perfect. Thank you, everybody.
Thank you, Kurt.
Thanks,
Outstanding
everybody.
briefing.
Have a great week. Bye-bye.
You too.
Buen día, buen día.